Right. Well, I make it 1 o'clock. As I said just earlier, as people were joining, Tom's had to give his apologies. He's been called away to something else, so he's just asked me to get going and to introduce myself, which I'll do in a sec. Just a reminder that Grand Rounds is recorded and the videos will be available on the YouTube channel as usual. If you're joining, if you could mute your microphones just to ensure there's no background noise and distractions. And hopefully we'll have a bit of time if there's any questions or discussion points at the end. So, my name is Chris Pell. I am currently working as a locum consultant psychiatrist in general adult psychiatry up in the North Angus CMHT. I also have a role in the St Andrews practice, which provides neurodevelopmental assessments. So for full information, conflict of interest, that sort of thing. But we are increasingly seeing in the adult psychiatric services people coming forwards with a wish to be evaluated for ADHD. And it's off the back of that kind of upswing in demand that I thought this would be a timely presentation. It draws on some of the slides that we've presented at the postgraduate teaching in psychiatry, and some of that has been contributed to by my ST4, Dr. Chelsea, and also our neurodevelopmental lead nurse, Erin Gerard. What we'll do is run through the kind of general descriptions and classifications as to what we actually mean when we're talking about ADHD in adults. We'll also have a think about what can we say, if anything, about what ADHD is from a neurological point of view, what etiological findings are there, where we're going with treatment strategies and why, and then thinking about particularly in the adult population, why has there been this upsurge in demand for assessments? Why is it not as straightforward, perhaps, as it might initially appear, and what are the kind of wider implications for services tackling this challenge? So it's probably helpful to define what we're talking about. The kind of common image of having too many tabs open in your brain is often the go-to, and that's been a kind of theme that has come through the ages. It's not a new thing, is probably the key bit to get across. So as far back as the 1700s, people started to talk about an attention deficit, a lack of attention in the literature. Melchior Vicard describes mangelnde Aufmerksamkeit. And this was kind of in the neurological descriptions. Towards the close of that century, Sir Alexander Crichton gave the first example of a disorder similar sounding to ADHD, and it's always difficult to retrofit some of these things back so far, but he gave a definition of people having the incapacity of attending with a necessary degree of constancy to any one object. And it actually encapsulates quite a lot of the difficulties. So it's not a lack of attention, but it's being able to put the right amount of attention to an object with a degree of constancy and not have it pulled away by other distractors in the environment. It's something that's pervaded through popular culture. So there's an 1845 collection of kind of cautionary children's tales by Heinrich Hoffmann called Der Struwwelpeter. And it contains the story of Fidgety Philip. And he is a young chap who is in the picture there, who is sitting at the dining room table, swinging backwards and forwards because he's so restless and fidgety internally, and eventually swings his chair backwards and forwards. And despite the telling off he gets from his parents, things get even more agitated to the point where he falls backwards and pulls the meal and tablecloth over on top of him. And again, the sort of context for it in the second verse, see the naughty, restless child growing more rude and wild, puts that kind of moral framework over it. And that was what carried forward into what we might call the kind of modern era of descriptive psychopathology and classification in the 1900s. So initially described as a disorder of lack of moral control by Dr. Still. And again, there wasn't very much more development around that. There was an assumption that there was something different or potentially damaged in the brains of people with hyperactivity, and it was described as post-encephalic behavior disorder and then minimal brain damage. But we start to get in the sort of 60s, 70s, and into really modern times, its inclusion as a distinct diagnosis in the DSM and ICD classificatory systems. So DSM 2, 1968, describes hyperkinetic reaction of childhood. So again, keyword being of childhood, and that was where it was lodged in that chapter around the classificatory systems for most of the time. It was seen as a disorder of childhood, with the implication that it wasn't a disorder of adulthood, and therefore that people moved through it, grew out of it, and the symptoms diminished over time. It's not until we get to the DSM-4 in 1994 that there's a recognition of adult ADHD. And the key thing there was that it sets a starting point that symptoms had to be present before 7 years, but it didn't put a kind of end date to that. It also introduced the subtypes of predominantly inattentive, predominantly hyperactive, or a combined subtype, and those have kind of stuck with the classifications going forwards as well. The latest updates in the 20 teens, DSM-5 shifted it from the childhood section to the neurodevelopmental disorders section, and also broadened the criteria somewhat in that symptoms had to be present now prior to the age of 12. So there's a widening of the age range and a slight reduction in the number of symptoms that were needed. And the same with the ICD-11, which followed a few years later. Attention deficit and hyperactivity disorder was placed in the neurodevelopmental disorders section, and it preserves those subtypes. So the current diagnostic features, these are the kind of core things that we are talking about from a diagnostic point of view. So these are persistent symptoms of inattention and or a combination of hyperactivity and impulsivity, out with what is expected for the normal age or intellectual level for the person. There needs to be a number of inattentive traits, so difficulty sustaining attention, being easily distracted, difficulty remembering to complete tasks, particularly the more mundane and those requiring greater levels of organization, and that there may not be that level of inattention if the task is very interesting and stimulating to the person. And also then the hyperactive side of things, excessive motor activity, feeling like they're driven by a motor, internally restless, difficulty engaging in activities quietly, difficulty waiting turns, and then the kind of impulsivity, tendency to react in response to immediate stimuli, rather than thinking through the consequences of their actions. Again, ICD-11, which is where this is from, describes symptoms prior to the age of 12 must be present. But again, it adds a caveat that it may only come to clinical attention later, when the demands of life exceed somebody's ability to compensate or mask them. Shouldn't be better accounted for by other mental disorder. It shouldn't be due to the effects of stimulants and other substances that have been taken. So it gives us a nice label, and that's essentially what all psychiatric disorders are. They are descriptive labels that apply to a cluster of symptoms that are held to a certain degree, and that cause distress or impairment to an individual. Where can we go with that in terms of, where do these behaviors arise in the brain? Are there any changes that we can see from a neurological basis that might help us, with what ADHD actually is. Just a reminder, if everyone could mute their microphones, that would be helpful as a bit of background noise. Neurological underpinnings have always been the thought. So ADHD has always felt to have been a kind of brain issue, even as far back as the 1790s with the original descriptions, that there was an assumption that there were disruptions in nerve functionings. Dr. Still, an ironic name for the researcher of ADHD in the early 1900s, said that there were irregularities in brain cell metabolism. There was the recognition as certain types of drugs became available that you could modify the behaviors, and amphetamines were noted to have an impact on the restlessness and the inattentiveness, but without causing EEG, without changing the EEG abnormalities that were seen underlying it. And EEG was the go-to really in the days before CT and MRI were around, certainly from the investigation of psychiatric conditions, to the extent that there was the photometrazole test in the 50s. And this was the process of gradually titrating somebody up on metrazole, which is a powerful proconvulsant drug, at the same time as hooking them up to an EEG and flashing them in the face with a bright light in a stroboscopic manner. And as soon as you started to see the EEG teeter into seizure activity, that gave you your kind of dose threshold, and you could give them an anticonvulsant to stop them having a seizure. And that was thought to say something about brain functioning. And again, this was done a number of times, mainly on children. Not sure you would get past the ethics committee nowadays, but they felt there were some, again, synaptic resistances, so differences in signaling in different areas of the brain. It's not until we get to the kind of 80s and 90s that more sort of what we might see now as conventional imaging technologies were available. And that's allowed us to expand a little bit and see, what is going on. So we can look in different degrees of precision at the brain as to what is going on where. We know that the types of kind of core symptoms, so reward response, arousal, executive function, and attention, correlate with activity in particular brain regions. So we know, for example, that with the reward systems in the mesoaccumbens pathway, that is a dopaminergic pathway. And in people with ADHD, there is an atypical response to things like reinforcement, praise, being able to delay gratification or to modify behavior in response to negative outcomes. We know that with arousal, there is the kind of Yerkes-Dodson curve, the inverted U shape, that you need a certain degree of optimal arousal in order to function in tasks and to maintain attention on them, to maintain optimal levels of engagement. And that in people with ADHD, there is a general hypoarousal compared to people without the condition. And that might lead to novelty seeking and needing a higher threshold of novelty and reward in a task in order to stay engaged and to stay on focus with it. It might also help to explain some of the difficulties with sleep and impulsive eating and these sorts of difficulties with emotional regulation. And that tends to be more of an noradrenergic pathway. Executive functioning, so the ability to do the top-down processing and to sequence, order, and work through tasks in a logical manner, being able to monitor the amount of attention and resource that the brain needs to give to a task, and to dial down the inputs from the external world. Again, frontal processes that are to a degree controlled by noradrenaline and dopamine. And again, similar with attention in the frontostriatal and frontoparietal networks. So, lots of things pointing in a particular uh, area. We know about the connections between these different areas. So there have been animal studies developed, so looking at lesion studies in mice, and where you have lesions between the frontostriatal and frontal parietal pathways, you get animal models of ADHD. Um, and that starts to bring us into things around the default mode network and the task focus network, which are two kind of key systems in the brain that we'll come on to in a little bit more detail. Um, Task positive network is the circuitry in your frontal pathways that tends to light up when you are focused on a specific task. So it's the thing that keeps you on target, that gets you into a good flow state, and keeps you in the zone. There's always, monitoring in the background that if something more urgent comes up, that you can shift your attention off the task and back to the surrounding environment. Conversely, when the brain is in a sort of resting or idling mode, when you're not involved in anything specific, the default mode network comes into play. And this is a set of pathways connecting the medial prefrontal cortex and the posterior cingulate cortex. There's links out to things like the temporal and parieto temporal junctions, the hippocampus, and it's where the brain goes in its kind of more resting state. So the daydreaming, planning and thinking more abstractly about the future, ruminating and going back over events that have happened, accessing memories, and the sort of idling, resting state. With people without an ADHD diagnosis, that there's a reciprocal arrangement that the task positive network firing up as you get engaged in a task leads to a quietening effect on the default mode network, and vice versa. In people with ADHD, that doesn't happen. There isn't a quietening down of the default mode network, so there are more of these distractions and wandering mind, difficulties with keeping an eye on the passage of time in the environment around, that lead to disruption of the task positive network and make it harder to stay engaged on a task. Interestingly, in people who have ADHD as a child and do have remittance of their symptoms as time goes on, half of them show a restoration of that reciprocal arrangement between the TPN and the DMN. So that's a helpful marker of what might be driving some of the difficulties. And as we've touched on, the kind of cellular and synaptic level to these things tend to run on dopamine and noradrenaline in these pathways. So we kind of conceptualize things as a dopaminergic or noradrenergic lack of signaling. And we've demonstrated this in genetic knockout mice. So taking the producing mice who don't produce enough of these neurotransmitters leads to ADHD symptoms. And yeah, we know it's not the be all and end all, because there do seem to be consistent findings of things in iron studies that iron deficiency in children doubles the likelihood of ADHD diagnosis. And it is linked to the development of D1 and D2 receptors, transporter proteins, and basal ganglion dopaminergic concentrations, but we don't really understand why that link is there. It's amazing the amount of stuff that we don't know about some of these brain processes, and we'll come on to that, particularly when we get to talking about female presentations of ADHD as well. And at the very basic level, the molecular and genetic underpinnings, we know that that there is a high level of heritability So only about 20 to 30% of the variability in ADHD is environmental. The rest is felt to be genetic. We do see neurodiversity running through families, and often when you've got somebody presenting for an assessment, through the course of doing a family history, it will emerge that, yeah, my brother's got ADHD, my cousin's got an autism diagnosis, my uh, father probably had it but was never diagnosed. These sorts of pictures are very, very common. Um, we haven't had much in the way of helpful studies, so genome-wide association studies, which have, big numbers, have given really quite mixed results. So there are a few genetic loci that seem to be important, potentially, ADHD-linked genes in the early development and cognitive development, but they overlap with a lot of other psychiatric and neurodevelopmental conditions as well. So we can say something about, there being uh, changes to signaling in the brain, and that is also kind of backed up a little bit with where we've got to with the development of treatment options for ADHD. Yeah, the posters from the olden days again wouldn't pass muster. Although it's interesting that we have now moved into a place where wellness and enhancing mood and staying fit and slim through other means, mainly Ozempic and Manjaro, are still in the news. But the treatment options for ADHD are stimulant medications by and large, or medicines that modulate the neuroadrenergic and dopaminergic pathways via slightly different routes through the reuptake inhibition. They've been around for ages. So benzodrine comes from the 1930s, a bit like pseudoephedrine. It was used initially as a nasal decongestant inhaler, and there's lots of overlaps between, pseudoephedrine and stimulants. In the late 1930s, Dr. Bradley was using stimulants in the children at a school for people with behavioral disorders. He was using it for headache, and this was from doing air pneumoencephalograms, which again was a common radiological means of imaging the interior structures of the brain in the days before CT. So you would remove the 50 to 100 mils of CSF, you would inject a bolus of air to fill that space, allow it to percolate up to the brain, and then image the brain once the ventricles had emptied. And you could see the internal structures of the ventricles because the air was now less radio opaque. It gave you a cracking headache, and different medicines were tried to alleviate that. It wasn't very good for alleviating headaches, but the educational staff at the school were curious as to what was being used because they were noticing improved attention, improved marks, improved overall behavior in some of the more disruptive children. So from that, they started to try and develop other stimulant medicines. Methylphenidate was synthesized in the 1940s towards the tail end of World War II, and it was used as that sort of pep pill to enhance concentration, enhance alertness, enhance wakefulness, and it was used, in the military, and these sorts of things are still used in war zones to into the modern era. It was that sort of general, yeah, a bit of a free-for-all in the 1950s and 60s that it was used as a tonic, pick-me-up, a thing for wellness. It started to become more problematic with the recreational use of these stimulants for their sort of buzz and euphoric effects. There was a lot of development in with illegal manufacture in the States in the 70s linked to biker gangs and things like that, which eventually led to controlled drug status being applied. So since then, there have been different things coming forward. So methylphenidate had been the mainstay. Dexamphetamine and its prodrug, lisdexamphetamine, were approved in the early 2000s. Atomoxetine, which is an SNRI, so serotonin and noradrenaline reuptake inhibitor, was approved around the same time, and likewise guanfacine, which is an alpha-2 adrenergic receptor modulator, were also approved. And that's really where we are. We have the stimulants, we have the non-stimulants, and we have a few that are theoretically likely to do stuff based on their receptor profiles, like aripiprazole, which is a dopamine partial agonist, which is currently licensed as an antipsychotic and mood stabilizer, but theoretically might boost dopamine signaling in areas where it's depleted as well. Viloxazine is another SNRI, and bupropion, again, is a antidepressant. It's used in psychiatry as an antidepressant, which again has a fairly broad receptor profile. But your key ones are stimulants, which boost dopamine and noradrenaline output, and the atomoxetine, guanfacine, and clonidine if people can't tolerate the stimulants due to the side effects, or if they don't have a good response. So why would you use medicines? Mainly because they tend to work pretty well. They've got some of the highest clinical effect sizes in psychiatry. So the Stefan Leucht paper in 2009 looked at the clinical effect sizes for psychiatric drugs, which are the blue dots on the right-hand side, versus treatments for physical diseases. So nice mind-body split. And he was looking at showing that psychiatric treatments have reasonable clinical effect sizes alongside other physical or equivalent to other treatments for physical conditions. Amphetamines and for ADHD and methylphenidate in ADHD have effect sizes around the level of giving methotrexate to manage rheumatoid arthritis, or giving metformin to reduce your fasting blood glucose, which nobody would think was controversial. So again, it's trying to put it into that context. There was a big meta-analysis just released earlier this year, Ostinelli et al. In Lancet Psychiatry, looked at 113 studies, nearly 15,000 participants, and showed that stimulants and atomoxetine were the only effective interventions in reducing ADHD core symptoms, and that was over a 12-week timescale. But they didn't necessarily improve other measures like quality of life. However, there are some earlier studies. So the Power Square study 2019 did look at those particular things and showed that people with a diagnosis on treatment had better quality of life, better self-esteem, greater work productivity and functional performance than matched symptomatic but undiagnosed and untreated controls. And I think, that sort of wider impact. So not only does it reduce the core symptoms, but it also has knock-on effects into people's general life. So there are individuals, not only to the person, but also from a societal point of view. So health costs, risk of injury. So this is a paper that was looking at cumulative risk of injury in adults with ADHD and people without ADHD, and then in table B, ADHD patients on treatment versus people not on treatment. Again, there's significant differences there. The overlap between mental health conditions in ADHD, if you can treat the ADHD, it makes them better able to engage in other types of treatment if there are psychological therapies that need a degree of focus and attention and concentration to get the benefit out of. Things like unplanned pregnancies, 2 times risk of unplanned pregnancies in women with ADHD compared to neurotypical women, particularly in kind of younger teenage years. Criminality, so all association between all cause sort of convictions. If you're on medication versus not on medication, it's significantly you're significantly less likely to commit crimes if you're on treatment. Traffic offences, traffic accidents, all of these sorts of general things that are worse if somebody has ADHD and it's not treated. So you can make a huge improvement just practically by getting people onto treatment and alleviating the difficulties that come with the core symptoms. It's not just medication. There are other things that are of benefit where people have difficulty in structuring, planning, sequencing, organizing. We're living in a world where we have access to lots of these things to be able to automate reminders, alarms, to be able to use time management aids. Apps are blossoming to help people with time management and planning and sequencing tasks. The latest ones are going into the kind of AI domain. So if people are interested, Goblin.tools is one that uses AI-powered LLMs to break down tasks. So you give it a task that you need to complete, and it will generate a list of steps in a logical order, and you can break down those steps even further if you need to. Social scaffolding, having people around you to help organize, and that often reduces as people get older and move into adulthood. That when you're in childhood, you have quite a structured routine, and your timetable in advance. You are helped hopefully by parents or guardians to have you got your bag? Have you got your PE kit? Have you got your keys? All of these sorts of things that, as you get older and life becomes more complex, fall away. ADHD is recognized as a disability under the disability legislation, so looking for reasonable adjustments in academia or in employment, and there's good links on the government websites about what sorts of reasonable adjustments might help somebody with an ADHD diagnosis. Peer support and third sector support. So there are a lot of charitable organizations. There are increasingly peer support groups popping up all over the place, partly as a response to services no longer being able to provide a diagnosis and treatment in a timely manner, but they do offer really good supports and really good kind of ability just to talk through what has been helpful for people, for carers support as well. So that's kind of what ADHD is from a psychiatric point of view. That's what we do with the treatments. The conversation, I guess, in wider society of late has been around, where are we with overdiagnosis? So it seems like ADHD has become much more common, and I think there were 2 things that have driven that: the pandemic, which seemed to unmask or led to people realizing that the way that they coped with and adjusted to the changes that were wrought almost overnight in the pandemic as lockdowns kicked in and furlough applied, they saw people around them coping with these changes in a different way to the way that they were, and a lot of people were kind of left wondering, well, what is it that means this has been so difficult for me to adjust to? What could this be? So I think that's unmasked quite a lot of the differences. A lot of people that had been getting by, perhaps without questioning whether they had an ADHD diagnosis or not, and similarly with other types of neurodiversity and neurodevelopmental conditions like autism as well, and social media. There is no getting away from it that social media as a technology is very, very good at spreading information. It is not necessarily good at flagging what is good information and what is poor information. Um, there's a few studies that have looked into the hashtag ADHD. Karasawa just came out in March 2025. They had looked at the top 100 TikTok videos that had the hashtag ADHD. Those 100 videos had a collective 500 million views, and less than 50% of the claims made in those videos aligned to DSM diagnostic criteria. So most of the information was inaccurate or misleading from the point of view of aligning to recognized international diagnostic criteria. They also, and that kind of chimes with other studies that have been done, and the estimates are anything from 50% to 96% of all videos about ADHD on these kind of short, TikTok or Reels or very social media driven things are inaccurate or misleading. The Karasawa study also followed up by showing a group of students the top 5 and bottom 5 videos of those 100, and afterwards, assessing their kind of attitudes and reactions to ADHD. More of them expressed a willingness to share information about ADHD regardless of accuracy, and that's what the algorithms do anyway. So as soon as you click on, some of these things, you will start to get flooded and bombarded with more of it. It also led to them having a greater estimation of the proportion of people with ADHD in the population. So they assumed that a wider proportion of people had ADHD compared to what is generally accepted and measured in studies. And I guess there's this splitting, as often happens with psychiatric terms, into almost a lay definition of somebody with ADHD, in the same way that people with obsessive compulsive disorder, people will say, "Oh, I'm a little bit OCD," or and they just mean they like things to be a certain way. I guess we're in danger of the same thing happening with ADHD. People will assume that they are a little bit ADHD, and that's not really a helpful situation to get into for people who do have the disorder and who are more likely to benefit from the treatment. So all of that has led to raised cultural awareness, more news articles, more discussion, more debate in popular culture. There's been an increased professional understanding, and certainly it has driven a lot more in the way of conferences and podcasts and educational meetings around ADHD. Its recognition as a disability, I think, has helped to shift because people are more likely to come forward if there's something that can usefully come of it, whether that's treatment or whether that's things like workplace modifications to allow them to do their job more effectively, and so that kind of increase in support is perhaps a positive reason why more people are coming forwards. I mean, it's a bit of a tricky balance because on the one hand, you've got all of this kind of information and more people saying, "Oh, maybe I've got a little bit of this." On the other hand, we know that we spent a long time not recognizing ADHD in adults because it wasn't a diagnosis in the classificatory systems until at least the mid-90s. The kind of general teaching when I sat at the MRC Psych, the thought was that only 10% of children with ADHD went on to have symptoms by the age of 30. So, if we've got 5% of kids with ADHD, then really only, a very small proportion of adults would have it. subsequent studies show that actually it's more like 50% of children with ADHD have persistence of symptoms into adulthood. And we also don't diagnose all the children who have the condition, particularly people who are, brighter, more capable, who can get by in the very structured environment of primary and secondary school, and do reasonable, but who may then fall into difficulties as life becomes increasingly complex and demanding later on. There have been attempts to try and quantify the total number of people symptomatic in the general population. So, Song, again, a meta-analysis, looked at the persistent ADHD. So that was children who had had a diagnosis and carried it forward into adulthood, and they found that 2.5% of the general population fell into that category. When they looked at people who were symptomatic of ADHD, so this was, going through the rating scales enough to conclude that they would meet the criteria for a diagnosis, whether or not they'd been diagnosed in childhood, nearly 7% of the population had, met those criteria. So for a Tayside population, or Tayside adult population, there should be somewhere between 9,000 and 23,500 symptomatic adults. They may not all realize that they have the disorder. They may not particularly want to do anything about it. But, it is probably a lot more people than we currently expect to have it. And the other side of it, looking at people who come to psychiatric clinics, almost 1 in 4 may have ADHD as a comorbid condition to what they're seeking help for. There are groups of people, and 50% of the population, well, slightly more, have been completely, are only starting to get recognition in the literature and the studies that there is actually a slight difference, and the reasons that ADHD may have gone unrecognized in women. It was always seen as, the naughty boy that was jumping about in class and not able to sit still. Female ADHD is generally more on the inattentive side. It's that internally restless, the bubbling of ideas, not able to sit at peace, not able to relax, always needing to be productive and having lots and lots of ideas, and that leads into levels of higher anxiety and depression or emotionally dysregulation. And in the past, that may have been diagnosed as other conditions. Women are also much better adept at building supportive structures. They are better at socializing than men, and they tend to have greater support networks, which may mitigate and protect against some of the difficulties. And there's better masking, so being able, more socially capable and camouflaging some of the traits and difficulties. But conversely, that's more exhausting and more effortful. The other bit that is really important, and again, only just starting to be looked at, is the role of estrogen in the regulation of the sensitivity of dopamine receptors in the brain, and its role in dopamine synthesis. And we know that, through the course of a general female life, there are huge shifts. So we have increases in estrogen levels through puberty, variation through the menstrual cycle, and so there may be periods of a month where the dopamine signaling is not as robust because the sensitivity of the dopamine receptors has been reduced by the relative lack or increase in estrogen levels. We know that these coincide with increasing complexity of life, and that may be a reason why things only manifest later in the lifespan. As people enter the perimenopause phase, the regularity of these changes in estrogen levels breaks down, and the overall estrogen levels drop. So there's again until the postmenopausal phase is hit and progesterone levels balance out, that there is still a reduction in the sensitivity going on. And again, it's a common life point where women come forwards, in their 40s, 50s, saying, I used to be able to cope with all of this. I really don't know why I'm not able to manage. I've got brain fog. I'm not able to organize stuff. I just can't multitask in the way that I used to. And again, when you look back and take the history, you can see actually, this is an unmasking of a previously undiagnosed ADHD. There isn't space on the chart to put in the changes in estrogen levels through pregnancy, but again, estrogen levels rapidly and greatly increase through pregnancy and then crash down at the point of delivery and are quiescent and at a lower level once baby has arrived. And again, that's the time that you perhaps need to be able to concentrate and juggle tasks and manage your attention better. And actually, your hormone levels are not helping with that process at all. The added complexity to the picture, as I try and rattle through these last few slides, is the overlap between other psychiatric symptoms. So all of psychiatric diagnoses are descriptive. They pick up on clusters of clinical symptoms that are to a greater or lesser degree out of keeping with what you would expect. And a lot of them are similar. So if we just take depression as an example compared to ADHD, there are some things you can pull out on the left-hand side that would more likely be diagnostic of ADHD. So seeking novelty, withdrawing oneself to self-regulate. If you feel overstimulated, you quieten down to regulate that. Hyperactivity and impulsivity. On the right-hand side, things that look more like diagnostic features of depression, so pervasive sadness rather than changeability of mood, poor concentration as a change in normal functioning, and across all domains, anhedonia. So it's not that you've lost interest in a hobby because the novelty is gone. It's a withdrawal from pleasurable activities more globally. And then in the middle, you've got things that could be seen through either lens. Sleep difficulties are very common in ADHD, and early morning wakening and insomnia is very common in depression. And it's the same all the way down. So again, trying to tease apart what is coming from what helps to see perhaps why people might not have been diagnosed with ADHD and might have been diagnosed with something else over the years. More than 50% of people with ADHD will have a second psychiatric disorder at some stage, which is greater than the general population. And as we've said, about a quarter of people who come through the psychiatric clinics will also have ADHD. So when you're diagnosing somebody with ADHD, you might want to be thinking, and what else? Because the likelihood is that that there will be some other coexisting difficulties. And when you're seeing people in clinic, as we do regularly, I often see people and think, have we perhaps missed something here? Have we been treating this as X when we've not taken into account there may be a comorbid neurodevelopmental condition alongside? Rates in all of the common disorders are higher in people with ADHD. Rates of ADHD are more common in people with other comorbid mental health conditions, and they're all greater than the general population. So that's just what the table is highlighting. So it's complicated. It's not as straightforward as it's all social media. It's leading to where do we go with all of this? And there are good guidelines there. So NICE guidelines, the Royal College of Psychiatrists in Scotland is a very good document that looks at making sure that people are taken through a multidisciplinary assessment, that time is taken to capture the symptoms in context rather than relying on kind of tick boxes, which may be useful screeners, but don't actually give you useful answers. And being able to develop people's abilities to self-manage with a combination of medication and psychosocial strategies. We tend to look at the ASRS as a useful, quick screening tool. If somebody doesn't score highly on that, it's probably not worth pushing forward for the full diagnostic assessment. But if you do, then the NATE, so the early neurodevelopmental history questionnaire, is very useful and gives a structured way of looking through other things that might play a role, things like early trauma, and then the DIVA is the diagnostic interview, which is again a structured tool to guide a conversation and to capture information in a clear and coherent way that aligns with the diagnostic classifications. It is a challenge, and services are struggling to keep up with the demand. There are a number of conversations about how health boards can manage this uptick. I think a lot of people have been pushed into seeking assessments privately, and again, the quality of those assessments can be variable. That was I think the subject of a Panorama documentary a couple of years ago. And for a lot of people, the wait is going to be too long, and in the interim, there is still damage accruing in their life. So I think we do need to find ways to respond. Angus has gone down the route of developing a neurodevelopmental pathway, which is increasingly trying to look at the information being gathered by other professionals than the psychiatrist, but preserving that discussion with psychiatry, psychology, and nurse neurodevelopmental champions to give that kind of multidisciplinary decision, and then to allow treatment pathways to open up if people are diagnosed. But it is a challenge, and I don't know that we have the right answers yet. But it can be transformative if we get it right and make a real huge difference to people. Thank you for listening. Happy to take any quick questions and comments. Just seeing if there's anything in the chat. So, TSL psychiatry service is open to commencing ADHD patients on medication. Yeah, I think there have been changes for pediatrics. It's slightly out of my bag, but yeah, I mean, ideally you would want to be able to keep up with the demand for both, because the more children you pick up, the fewer adults there will be to pick up down the line. And also in terms of life course and life trajectory, if you can get treatment in sooner and help people to maintain their expected trajectory rather than being pulled into some of the social and educational difficulties that they might fall into. Again, huge problems with people getting in with a bad crowd, doing impulsive things that they later regret and haven't thought through the consequences of. If you can get in early and alter that trajectory, then that's to their advantage. Sources of information, sources of support. I mean, I tend to suggest some of the kind of self-help places. So there's the Attitude magazine, ADDITUTE, which has loads of information. How to ADHD by Jessica McCabe is a really good introduction to adult ADHD and some of the difficulties, with a lot of kind of practical strategies and a kind of online presence. Um, just flicking through training for GPs with extended roles in ADHD diagnosis and management. There's lots of stuff through the Royal College of Psychiatrists, so webinars and conferences that would equally be of use. I think that some of the companies that produce the medication, and again, there's issues around conflict of interest and things like that, but they also tend to have portals that people can log into to access training resources. Um, yeah, yeah, variability of assessment at private clinics. I think, if people are going to head towards a private diagnosis, the thing to make sure is that that private clinic is using the guidelines that are set out in NICE, really, that having a multidisciplinary approach using the gold standard assessment tools and the process that is recommended. I think, yeah, watch the Panorama documentary, and it will highlight some of the differences in process. Um, Evidence base for the idea that ADHD and some anxiety disorders have increased in the digital age. Yeah, I mean that's a fascinating one. And I mean, we know that we are increasingly becoming cyborgs. So we are we are tool using species, and we offload some of our uh, uh, physical parameters into the tools that we use. So we no longer have uh, you know sharp teeth and claws because we can throw stones at people. We have evolved into these things. So digital devices offset our memories. We are increasingly reliant on the devices we have. It's the difference between knowing what your significant other's phone number is versus being able to access it immediately when you need to get hold of them. And that shift from everybody memorizing telephone numbers to just relying that it is there is starting to shape brains. There were some studies that looked at heavy users of sat nav, like taxi drivers, HGV drivers, and there were some associations between poorer development in their kind of parietal lobes, so the kind of spatial awareness, because they weren't using it as much as they had done in the past when they were reliant on maps and signs and all the rest of it. So possibly, I think there's mixed studies out there, and it's that tension between technology being useful versus unhelpful, and I think it's the way that technology is being used. There's certainly popular concerns about the effects on children's brains of being constantly bombarded with quick, easy, if you don't like something or it gets hard, flick, flick, you flick, and whether people are able to sustain concentration anymore, even to the degree that TED Talks have shortened their talks because they don't feel that people will sustain their interest in things unless it's very compressed. And that might be useful. Maybe it's increasingly efficient about communicating. Um, but there's that worry about, well, what are we not doing? What are we not practicing? What are we not teaching that might be detrimental? And yeah, similar links with anxiety in all of that. I think it's Hates the Anxious Generation is a book that kind of deals with that problem. Will an increase in diagnosis have a future impact on the criminal justice system? It ought to. If people are identified early and treated early and don't fall into the difficulties that they might otherwise have, yes, potentially it could. I mean, certainly there are high levels of ADHD in the criminal justice system, so maybe there's an opportunity there to mitigate things or to identify things or strategies that might be helpful. How can you increase the accessibility of services for families with ADHD? Again, I think that's where the peer support and the third sector are useful. And that's probably in this kind of era of constrained resources, um, probably the way that it will have to go for a time. Um, I think there's also that kind of, we may reach a tipping point because I think the other bit that's in the background around this debate is that we live in a very neurodiverse world, and I think the increasing recognition, the reduction of stigma around all of these things should lead us to a place where, our educational strategies should cater for everybody's, neurodiversity. That we shouldn't be saying, well, these kids need special help and they get that. Just design environments, design teaching programs, design workplaces that actually support everybody with the way that they interact with the world and the way that their brains fire. There are significant benefits to ADHD brains that they are very good under pressure at a deadline where there's a lot going on at once and everything needs done now. And that's a real advantage. But it's harnessing that and getting people into the right roles and supporting them with the right kind of pathways to get there. Right. ADHD in women often presents with different symptoms. Yeah, absolutely. Yeah, clinicians need to better tailor their assessment to support approaches to meet the specific needs of women. Yep, totally agree. I think there's the historical image of ADHD is we're moving away from that, and I think the particular recognition around ADHD presenting in women is still filtering through. But yeah, increased awareness definitely, and I think I think that is the key to it, of thinking, could this be ADHD? If somebody is very anxious and distressed, is the anxiety coming from the fact that they feel constantly overwhelmed by all the stuff that they need to do, and looking at kind of key transition points in life. So, leaving the parental home and living independently adds that layer of complexity. So the scaffolding is gone and life has become more complex. If it kicks in at that stage, could it be because the ADHD is unmasked at that? In the same, when a child comes along, you've managed to get strategies in place that keep you on the rails, and you're doing your job and your home life. We know that women have a greater home administrative burden comparatively than men on average, but you've got strategies in place that keep you on track. And then a child comes along and you have this whole other person's life that you have to organize as well. It's looking at all these kind of points where, could this be ADHD? Could this be a sign of neurodiversity? Could this be overwhelm? Could this be unmasking of symptoms? Lots of potential to get into that. Yeah, medication. What are the factors that lead to ambivalence and resistance? I think again, psychiatric disorders struggle with the stigma, and medication is seen as a crutch. Whether it's an antidepressant and it's masking your symptoms, and you should just be able to pull yourself together. It's that kind of try harder effect. People. There's a sense with people's behavior that they ought to just be able to better control it, and that you shouldn't need to, rely on a medication to manage that. But actually, there are distinct differences in the signaling pathways in the brain that mean it is sometimes impossible to just apply the psychosocial things and expect it to work in the same way as it would with somebody who doesn't have an ADHD brain. I think with them being controlled drugs, with them being related to amphetamines, again, that adds another layer of complexity to it. People might be put off. Often stimulants are seen as bad things. People abusing speed and things like that. And again, there's that sense that, maybe there's loads of people coming forward because they just want to get hold of some prescribed amphetamines. I don't really see that in practice, maybe a very, very small proportion of people, but it's an awful lot of hassle to go through just to get some Ritalin or some lisdexamfetamine prescribed. You'd probably be easier going along to the dodgy bloke at the end of the road and just buying it. So again, I think yeah, all sorts of bits factor in. Um, yeah, so ADHD medication being used long term, yes. I mean, they don't tend to wear off. Once you get to the threshold where it's working for the individual, there isn't the same sort of, we don't tend to see tolerance or dependence emerging. That you get it above a level, and then that is sufficient to maintain the signaling pathways more effectively. Um, David Walsh, diagnosis of ADHD in a forensic setting. Commonly self-reported diagnosis in a custody setting, hard to diagnose accurately due to the high level of comorbidity, yeah, and the overlap of symptoms, drug use, yeah. I mean, it's hugely complex, and also all the trauma that has gone on in that person's life as well, because again, trauma will lead to dysregulation of affect and emotional regulation. It will lead to heightened arousal states. It will lead to impulsivity, and that's the most common discussion that we have in our multidisciplinary meetings. That the nurse will present a case, and then we're trying to, yeah, there's a lot of trauma here. Do we need to treat the trauma bit first and try and get that under better control before we can see, is there still a signal there of ADHD at the end? But conversely, if they do have ADHD, they might be better able to engage in the trauma-focused work if they can attend and concentrate and stick to it. So it's a perpetual debate. Um, and I think I've just got to the bottom. Is there any particular research about the incidence of undiagnosed neurodiversity, ADHD, amongst certain professional groups, e.g., medics? I've not come across, and partly I've not kind of looked, but I would imagine the levels are pretty high. I think within an audience of this size, there will be lots of people with neurodiversity, lots of people who live in neurodivergent households, because it's common. And again, hopefully, we're in a world that is moving towards greater recognition and greater acceptance, that not all human brains work in the same way, and that's to be celebrated rather than classified and diagnosed. And I think the discussion in the classificatory systems as it comes through are increasingly, should we have this word disorder attached to things like ADHD and autism spectrum? Is it just should we be applying a more broad definition of what the full range of human experience is, and how people relate and interact? So I don't know. I would hope that we get to a stage, like I say, where it's just taken into account that, in a classroom of 30 kids, 6, 7, 8 of them might see things in a slightly different way, and that we incorporate that into our ways of teaching, our ways of doing things. Yeah, I'm not sure I'd go with ADH personality, but yeah, it's we we know the labels are inadequate at times, and we know that they are placeholders for the etiology underneath that we're still only scraping the surface of. Right, past the time, so we'll call it there. Thank you very much for your attention. Thank you for the interesting questions, and I hope everyone's enjoyed it. You can catch up on the YouTube channel, and hopefully things will be back next week with Tom in the driving seat. Thank you.